Okay, hello everyone. Chad and I sort of work very closely together, and we'll introduce him in a sec. I think we're probably both going to present, and then we'll give you a chance, for all of us to discuss at the end. So in my talk, I want to show you how we leveraged big data studies and smaller sample studies to iteratively learn about previously unknown characteristics about dental opioid prescribing. If you go back 3 years, 3 or 4 years, our profession was still in denial about our impact on the opioid crisis. So hopefully we are all now well aware of our contribution and how we can correct that. But I too have been an overprescriber of opioids, and I contributed to the opioid crisis, by prescribing just in case, right? And I want to talk to you about how we created an iterative learning process around dental opioid prescribing. So as you can see, we have a very, very large team, really led by Chad and a couple of others. There are medical students, dental students, public relations, videography, political affairs, a lawyer, and an anesthesiologist, Chad, health policy experts, hand surgeon, transplant surgeon, truly a multidisciplinary team, and absolutely my privilege to be a passenger on this train. So, the first study we did in this space showed us that dentists introduced many opioid-naive individuals to opioids every year through wisdom tooth extraction. And here's some of our findings. Since wisdom teeth mostly erupt between the ages of 13 to 30, this is relatively young and healthy population, but we subject them to their first opioid prescription. We frequently subject them to their first opioid prescription through their dentist, through dentistry. So a new friend of mine who I met on this journey, working in opioids, was actually one of the first to educate me about the role of dentists in the crisis. She told me that her dentist prescribed 40 pills for her wisdom tooth extractions, okay, which is fairly common, a couple of years ago, and now it's maybe still half that, which Chad and I hope to show you today that is still way too much. But anyway, she was prescribed 40 pills. Can you guess how many days she took to use up these pills? All right, I'll let you think about that, and I'll come back to that. Currently, the American Dental Association does agree that there's no strong evidence for prophylactic removal of wisdom teeth, and yet many still practice this way. Our recommendation from this study has been to deeply analyze the risks of not removing wisdom teeth. I don't think we do this enough. There's quite a few dentists in our group, in our small group here, and you'll know oroantral fistulas are created frequently. Only 13% of the time there is a surgical correction, but they're actually created frequently, and there are consequences to that, right? And then mandibular nerve injury happens frequently. Now, 96% of the time it recovers, okay? But when it's injured, there are consequences to that. And I don't think we think about all of these consequences when we do these wisdom tooth extractions, right? And then there's dry socket, there's inhibited bone healing, there's all these other things that can go wrong. And now we can add the risk of new persistent use of opioids, which we found to happen in 1.3% of cases. Now, you might say, Ramesh, 1.3% is not that much nationwide. But the thing is, every year, dentists take out about 4.5 to 5 million wisdom teeth in about 2.5 million unique individuals every year. And so 1.3% translates to 32,000 Americans becoming new persistent users of opioids after having their wisdom teeth out. And this happens every year, right? It's something that we should be very concerned about. There are numerous studies now published in the last decade that attest to the fact that non-opioid combinations are actually more effective for acute pain relief than after extractions, right? And more studies are being published about over-the-counter medications that have demonstrated better pain relief compared to opioids. in March 2020, the FDA approved an ibuprofen acetaminophen combination, and that will help facilitate the use of non-opioid solutions as well. So our study showed that young people ages 13 to 30 who filled an opioid prescription immediately before or after their wisdom teeth were removed were 2.7 times as likely as their peers to still be filling an opioid prescription weeks or months later. They had become new, persistent users. Okay, so back to my friend. She was prescribed 40 pills for her wisdom tooth extraction, and she was just beginning to experiment and misusing opioids, okay? So she finished those 40 pills in 23 hours, in less than a day, right? So that sort of gives you an indication. If you prescribe to the wrong person at the wrong time, it is disastrous. So I'm happy to tell you she is a recovering addict, 8 years sober, 2 children and a master's degree, and she's doing great in life. Okay, so, so after this big data study, right, we knew that we needed to speak to patients and really understand, talk to them and understand more in details that we cannot get from a big data study. So we needed to be speaking to patients. So we started, I guess, a small data study, if you will. We called 400 patients of the University of Michigan School of Dentistry who received an opioid prescription after an extraction. Okay, so actually at first we looked at all dental procedures and we found that 70% of the opioid prescriptions were associated with extraction, and so we targeted extractions only. So this is what we found, that roughly half of the pills were unused when prescribed for dental extraction. And actually it made no difference if it was routine or surgical. So straight off the bat, this means we are overprescribing opioids to the tune of about 50%. Currently, the ADA, American Dental Association's position on opioid prescribing has not changed since March 26, 2018, and it states that dentists should limit opioid prescribing to 7 days. Anyway, our collective experience at Michigan Open has taught us that this is far too high and results in unnecessary exposure and increased availability of unused pills, which are often shared with unintended end users. The next thing we found in this study is we found that patient satisfaction with pain management was no different whether the patient had opioids or not. Now, I think that was a really important finding. Sometimes we dentists worry because we want to reduce opioid prescribing, but we don't want hundreds of dissatisfied customers experiencing postoperative pain because of inadequate analgesia, right? But our study showed that there is actually no difference in satisfaction with pain management, whether the patient received opioids or not. And actually, this was no different for surgical or routine extractions. So one more finding in this study, we found that patients taking opioids actually reported worse pain. And again, it didn't matter if it was routine or surgical extraction. Our recommendation since this study has been for dentists to strongly consider eliminating opioids from their prescribing habits. There are alternatives that are evidence supported, that are they're more effective and have less side effects. So in fact, if you're prescribing opioids as a first line of defense for your patient, you may actually be doing them a disservice because there are more effective alternatives. Now, if a determination is made to prescribe opioids, this study also highlighted the importance of educating patients about proper storage and proper disposal because so many pills are unused. Okay, so next thing is, based on my own practicing habits. So, I practiced full time for about 7 years, and then I practiced at another, I taught and practiced at a different, like in Boston, another institution, and I saw patients on Thursdays and Fridays. And now for the last 5 years, I've been here at the University of Michigan, and I see patients only on Fridays. So for 20 years, I've seen patients on Fridays, right? And so in this study, so basically with all of that experience on Friday patient care, I suspected that dentists may be prescribing more on Fridays and before holidays. And the reason, again, is just in case, right? The prescription is supposed to hold them over before we reopen on Monday, or after the holiday. The problem is, during the opioid crisis, we've learned that this just-in-case prescribing turns into drug misuse and abuse. We should be aiming for, a precision health approach to prescribe just the right amount to the right person at the right time. So in this study, again, we used big data to compare Friday and pre-holiday prescribing to all other prescribing. We found that the adjusted odds of filling an opioid script from dentist increased 27% prior to weekends and holidays. And, as I said, I've observed this issue, and I'm guilty of this issue, although I've changed my practicing habits now. But I've observed patients request complex procedures like wisdom tooth removal or implant placement on a Friday, just before a weekend or a holiday, to facilitate recovery. And this study made me think, I never questioned that before, but this study made me think, isn't that funny? Because when you think of a minor medical surgery, right, like, in the context of medical surgery, like gallbladder surgery or something like that is minor, you don't then tell your doctor, hey, by the way, do it on a Friday so that I can have a nap and go back to work on Monday. But we do that with dentistry all the time. Like we frequently don't want to miss work. Like it's almost like it's not considered in the same echelon of surgical procedures, even though the pain and the recovery is significant. So in short, this study confirmed that my bad habit is a nationwide trend among dentists. And our recommendation now is that dentists should deliver complex treatments at the start of a working week so that they can limit opioid prescribing and monitor recovery more closely. Or alternatively, continue to deliver care on a Friday or before holiday, but have better support mechanisms in place to enable monitoring and to facilitate conservative prescribing. Okay, so we learned a lot about the magnitude of the problem of opioid prescribing in dentistry, and now we had to resolve it. And this is what I love about working with Chad and Michigan Open, is that the organization exists to obliterate this problem. Is not to publish about it. Because we are academics and scientists, yeah, we publish some articles, but the goal of Michigan Open is actually to get rid of this problem of the opioid crisis. So our approach here was to educate clinicians. So we started an interventional study. We studied the effectiveness of sending a health educator, not a dentist, a health educator, to rurally located community dental centers here in Michigan. Now, typically, these rural dental clinics are small. They lack the resources to implement a quality assurance program to identify and address opioid overprescribing in the manner in which I described at the University of Michigan when we call back all of our patients. These small offices don't have that layer of administrative support, right? So anyway, we provided a 1-hour training session to the office, to the officers, and a couple of 30-minute follow-up calls to teach them how to do this in a low-cost way. We also taught them how to use MAPS, Michigan's automated prescription system, which is our PDMP for this state. This was being rolled out just as we were rolling out this intervention, and we are funded by Michigan's Department of Public Health, and so we wanted to train how to use MAPS. Now, this is really important. We didn't tell them you have to reduce your opioid prescribing. We told them, call back your patients, see how they're doing, see how many pills did they actually take from what you prescribed. We believed that dentists would come to their own conclusions that they could dramatically reduce their own opioid prescribing. And we were right. Following the educational intervention, opioid prescribing decreased, knowledge and use of MAPS increased, more patients received pain management counseling and post-operative follow-up calls. Additionally, patient satisfaction and pain scores were not associated with the number of opioid pills prescribed. This study powerfully demonstrated that increasing provider education reduces opioid prescribing and protects patients. So now, it was time for another big data study, okay? So this time, we kept working on this issue of prescribing amongst dentists. And, we've become more and more convinced that dentists prescribe a lot. So this is an issue worth our attention. And, I became more and more convinced that dentists could potentially reduce their opioid prescribing to zero in most cases, which may not sit comfortably with everyone listening to this message. So anyway, in an effort to identify areas that we could get, the biggest bang for our buck, so to speak, we decided to find out, what are the most common procedures associated with opioid prescribing. So we did this in a big way. We looked at data from 2013 to 2018. We looked at big data from commercially insured as well as Medicaid insurance. We considered close to 10 million procedures in the age group 13 to 64. We already suspected that dental opioid prescribing is highly concentrated among a few procedures, because remember, before, when we called back patients of the University of Michigan, we found that 70% of our prescriptions were associated with extraction, right? So anyway, we found that 95% of prescriptions nationwide were associated with just 5 procedures, right? Which is quite interesting when you think about the hundreds of ADA CDT codes, the hundreds of unique treatments that we deliver, and that in dental schools we train students to deliver. Amongst all of those procedures, 5 of them account for 95% of the opioid prescriptions nationwide. I found that a little astonishing. So anyway, the procedures are 65% tooth extraction, 18.5% problem-focused limited exam. Now that's interesting too, right? Because that's not a definitive treatment. That's essentially an effort to postpone care, right? You do an emergency limited exam and write a prescription, which is not ideal. We should be accommodating those patients for definitive care and therefore prevent the need of opioids and prevent the risks associated with opioids. Okay, so 18.5% were associated with limited oral exam, nothing else. Another 7.5% was associated with endo, root canal therapy, 3% with alveoloplasty, and 1.5% with implant placement. Okay, so one more fascinating study, and not able to share all the data because we're still working on this. But we've worked a lot with insurance databases, right? Which includes family members. So we wanted to study whether an opioid prescription is associated with overdose in patients or their family members, the latter of which may have access to the patient's opioids, right? So we looked at data from 2011 to 2018. Again, commercially insured plus Medicaid insured. We focused on age group 13 to 64. And I can tell you that there is an association with overdose in the family member. So the thing about this is, when you prescribe opioids, you literally put the whole family at risk, right? So it's incredibly important. It's an incredibly important issue that we have to keep working towards, because we've only started scratching the surface in terms of correcting dental opioid prescribing. Okay, I will pause here, stop sharing my screen, and hand over to Chad. And our plan today was that we would both speak, and then we'll have a discussion at the end, if that's okay.
Okay, wonderful. So I'm Chad Brummett. I'm an anesthesiologist and a pain physician, and I want to just flip some good vibes back over to Ramesh and just say it's been an absolute pleasure to work with Ramesh and work through this really important question. Our group came together in late 2015, really the beginning of 2016, to take on the acute care prescribing of opioids, but in doing so, acknowledging we were really well suited to do surgery. And I'll talk to you mainly about our surgery data, just to complement Ramesh's work, but also just to say that we knew at that point dentistry was going to be important, but we did not want to be one of the groups out there that was putting data out in the world about dentistry without a dentist there to help advise and show this forward. We know this happens all the time. For what it's worth, it happens to physicians too when public health officials come at us. So we are really proud of this partnership. I have a few funding sources from the NIH. These are our active grants, as well as Michigan Department of Health and Human Services, SAMHSA, CDC, and then some institutional funding. I have an unrelated patent, and I consult for 3 companies, none of which are related to today's talk. And I do provide some expert testimony, again, not related to today. So when we came together in 2016, this was our concept, was that the entire country, the US, NIH, FDA, CDC, White House, everybody was focused on all of the downstream effects of the opioid epidemic. What do you do with the chronic opioid user? How do we get naloxone out of the community? How do we better manage people with opioid use disorder? And these are all important topics, right? These are all important topics. And in fact, Michigan Open's now working in all of those spaces, from surgery to the emergency department, distributing naloxone across our state. But at that time we said, well, what about this? How come instead of just focusing on, rather than simply focus on all of the downstream effects of the opioid epidemic, couldn't we take that person not using opioids before their dental procedure, know more about them, and help shepherd them through this pathway, not only to make them healthier, but then to help create healthier families and healthier communities. In other words, this was an opportunity for prevention, and I don't need to convince a group of thoughtful dentists as to how important good oral health is in preventative medicine. Well, in the same way, the way in which we prescribe is part of that preventative medicine. Now, early, so these are data that went through 2016, about a 7-year period, national claims data. We looked across this 7 years and said, who gives a person who has not filled an opioid in the year prior their next prescription? Adult patients. And this is what we found, is that over that 7-year period, and this is partially because of the preamble to the CDC guidelines, which is really focused on primary care and chronic pain, that the relative contribution of primary care decreased, even though primary care physicians are still by far and above the dominant prescriber of opioids in the US. The relative contribution of surgery, dentistry, and emergency medicine increased. And not only that, the amount prescribed and the increase was greater in surgery than it was in dentistry. But even over those last couple of years, we're at the bottom there in yellow, you see primary care physicians are not only prescribing less often, they're prescribing less per prescription when we break it into oral morphine equivalents, or OMEs. And dentists remained flat during that time. So I realized that we actually have more contemporary data coming out now, but I think this shows that cycle, and we would expect this to only be greater now because primary care physicians are doing better. So why do surgeons and dentists prescribe so much? And I would actually put pain physicians like me into the same category, right? So we're not immune to this. And really, through both informal conversations and then formal qualitative studies, these are the factors that we saw. People are worried about time. And there is convenience to just writing a prescription. It does get people out of your office. It does address somebody, and it does make them feel as though you've been attentive to their needs. We're worried about phone calls. So if we don't give them an opioid, are they going to call me on a weekend? The convenience prescribing for the weekend. Is it going to drop my satisfaction? And will that have a financial effect? And good news, and most of these are here that I have referenced for surgery, but we've done this in dentistry as well. There's no association between the number of pills prescribed and people's satisfaction with their care, nor is there an association with the number of pills prescribed and people's likelihood of refill. And so I'll give you examples in surgery. Abdominal surgery, you give them 6 pills or 60 pills, the refill rate's 7%. Doesn't matter if you adjust or don't adjust. If you take a total knee arthroplasty, you give them less than 15 pills or more than 150, the line's flat. In fact, maybe starts to bump up at the end, where higher pills associated with greater likelihood of refill, maybe getting people tolerant. And the satisfaction thing, look, could you Google Brummett right now and find somebody on one of these websites that says, Brummett's a jerk, he didn't give me my opioids? I'm sure you could find it. But now what if I transform my whole practice and prescribing based on that one event? The reality is, if I take a data-driven approach and I say, what matters for satisfaction? Well, for those that are local, our pain clinic's been working with Zing Train, the training and satisfaction group, the customer service training arm of Zingerman's, for, 7 years now. We're a chronic pain clinic. We tend to take care of people refractory to their care, people who have failed other clinics, and we have the highest satisfaction. We're the 5th highest rated clinic of the 140 clinics at the University of Michigan. And that is not because we're prescribing more opioid. We actually wean people. It's because we care for people. We talk to them. We call them back when they have a problem. All of the things that you do when you're walking in and out of the room, but more importantly, what your staff do, that's what matters. The oxycodone is not driving satisfaction. Now, Ramesh introduced this concept, but I want to let you know this is not just true for dentistry. In fact, these are some of our greatest hits. That top article there has definitely been the one that's been referenced the most. We looked at major and minor surgical conditions. We said among people not using opioids in the year prior, who keeps filling months later? In other words, long past what would be deemed normal surgical recovery. And we find no difference between minor and major surgery. In other words, it's the patient, not the surgery. And we see this across all domains, all types of surgery, including elective pediatric surgery and even cancer surgeries. And so it doesn't really matter what we look at. We see this, and this is now, when I'm talking to a group of surgeons, I say, becoming a new chronic opioid user is the most common complication after elective surgery. And I get about half the room with head nods and half the room looking at me like I'm a jerk, right? Because how is that a complication? Well, it's a complication because if you came in not using opioids, months later you're still using opioids, you have opioid-related morbidity, right? And that is by itself a complication. Now, what have we done about this? We have used this iterative process that's been talked about within learning health sciences. If you look at, this is statewide data from the Michigan Surgical Quality Collaborative. This is the preamble to Michigan Open. This is the average number of pills prescribed if we put it in 5 milligram oxycodone pills for a case mix of both major and minor general, gynecologic, and vascular surgeries. We came in and just started talking about opioids in July of 2016, that first line, and we started to get some move just by talking about it. We then released evidence-based guidelines from around the state, and we saw more move. And as you see, with each iterative set of guidelines, prescribing decreased to the point where now we're in a place where we're in about our third set of guidelines for at least these conditions, and we're starting to see a flattening out. So we've definitely decreased prescribing. This is probably 45,000 people. This is 43 hospitals around the state of Michigan. No perfect secret sauce, use this, use that. It's just, here's the number of pills prescribed and here's some education, right? We care about taking care of people. And despite the fact that people on Twitter like to say that I'm a terrible person, I don't care about people or pain, we did look at pain. We did look at pain and satisfaction. And this is what we found. As we saw that decrease in prescription, the hard black line, which clearly is coming down, we also see a corresponding decrease in consumption. This is consistent across. For every excess pill you prescribe across multiple surgery types, people use an extra half pill because you've given them more. This is the supersize me concept. The more I give you, the more you'll eat, right? It holds true for oxycodone and other things as well. So they'll use more pills without any improvements in pain, satisfaction, or refill requests. But when you give them less, they also take less. And as you can see, it doesn't influence their pain or satisfaction. Now, this is for surgery. The question is, does this hold true? Ramesh already put this forward. He talked about this paper. This was an important paper for us because this was one of the first studies we did that actually showed that just receiving a prescription mattered. A nearly threefold increase adjusted odds of becoming a new persistent user from just the receipt of a prescription. So then the question becomes, can we eliminate prescriptions? And we are not just looking at this in dentistry. So I think one piece of feedback I've gotten from dentists is, why can surgeons prescribe, but as a dentist I can't? And the answer is, there's many surgeons who shouldn't prescribe. And so we've been doing work across the space. So we've been working with Blue Cross Blue Shield of Michigan. We have some incentive models in place for people who are going fairly common surgeries, where they can be prescribed a much smaller than our current recommendations. So if our current recommendations say 10 or 15 tablets, they might get 2 or 4 tablets, emergency use. What we found is that as we looked across the many people across our state who are getting this, that when we give these small numbers of tablets with good education, encouraging non-steroidals, encouraging acetaminophen, the median use became 0. They had pills left over. Pain was well controlled, minimal pain, and people's satisfaction was high. We actually, and these data are now either out or pending with JAMA surgery. We did sort of a case control, not a perfect study. This is not an RCT. We are working on this idea of an RCT, comparing people who didn't get an opioid to those who did, and looked at their outcomes. And as you can see, pain scores were actually slightly lower in the people who did not receive an opioid. Not what I would call clinically significant, but certainly not a concern. Equal satisfaction, equal quality of life, equal regret, which is one of the measures for surgery. And as you can see, patients on average in the opioid group got about 7 pills, took about 2 pills. So just getting that prescription didn't seem to improve their outcomes. So I think this is the opportunity. I think the advantage in dentistry is you have level 1 data, randomized control trials showing acetaminophen and ibuprofen are equal or superior to an opioid without the morbidity of nausea, vomiting, and now new persistent use. So that's all I have for today. Thanks for letting me share. This is our website, michigan-open.org. I will encourage you to go there. We have a lot of patient materials there, patient-facing materials. If you're from an outside practice, we actually allow you to send us a high-resolution logo of your practice. We'll stick it on the front of the materials and send them back for free and clear use. They're available in English, Spanish, and Arabic. And then we've been doing work with the Precision Health Initiative across campus of the University of Michigan, which is how we're together with dentistry, public health, and even doing some work with the School of Music, Theater, and Dance. With that, I will stop sharing and hand back over to Ramesh.
Yeah, well, just if folks have questions, I mean, Alan, actually interested in hearing what you have to say, because your background is pharmacy, right, Alan?
That's correct.
Yeah. So for folks that don't know, Alan is a pharmacist, but now is a key person in the learning health systems movement at the University of Michigan. And your question about tracking the effectiveness of the guidelines, I'm not sure, that's a tough one. Maybe I'll handball that to Chad, but I put in the chat the dentistry guidelines for this state, which Michigan Open helped to write those. And you'll see that it is much more detailed and cautious than, certainly the ADA and perhaps even CDC and other state guidelines, because the idea is a movement towards zero. Something that I can attest to being a practicing dentist here is we never historically had conversations about alternative pain management strategies, like mindfulness and meditation and ice and things like that. We never had those conversations, but there's evidence for a lot of those. And so these guidelines sort of ask us to really have those conversations with patients. And, if all these other things don't work, then perhaps opioids is a solution.
Alan, maybe I could have you clarify the question. We published something just recently in BMJ Quality and Safety, kind of talking about our process. It has been an iterative process where we get data, we update the recommendations. We were very conservative initially. We started with the 75th percentile. So we had data from 43 sites, like 20,000 people. We said, okay, 75% of people use less than this. We made that our threshold, which brought a lot of it down. And as you keep stepping down, we did that 2 or 3 times. I will say with other groups, like the total knee arthroplasty group, where things were wild. I mean, wild. They actually went with the 50th percentile, and again, had no they've had no kickback. So how do we measure ill effect? Well, we measure ill effect through things like increases in refills, increases in pain, decreases in satisfaction, and then hospital admission or ER visits. And to date, we just see no ill effect. Now, what we are talking about currently and trying to find the right funding organization at NIH, because this would be a monster is we can bring it down, at least for surgery, without the level 1 data. Again, dentistry's ahead. Level 1 data in place. The evidence is there. People just aren't following it. In surgery, the evidence isn't there. So within the surgical community, can we do something similar, taking a group of minor surgeries, but some of the things that are the most common surgeries in the US, something like a laparoscopic gallbladder removal, and randomize people to opioids or not, and look at both pain, satisfaction, and then also any ill effects, which we foresee no challenges, but I think the trial needs to be done.
Yeah, thanks for that. I guess I have 2 thoughts in mind about the guidelines. I was thinking of your graph, actually, Dr. Brummett, when you showed, you had several stages of the work and you were showing the curve throughout those stages. And I think it mentioned various versions of the guideline. So I was thinking about what's driving the changes. to the guideline. Obviously you're getting new evidence. So the first concept I wanted to insert here is this idea of a living guideline, right? That people have written about and talked about, where, learning health system context, you're continuously collecting data, you're analyzing it, and as you learn more, someone interprets the data and decides, the guideline needs to be changed here, or this needs to be modified, and you publish a new version of the guideline. So I had that living guideline concept in mind, and how do we learn once we have a guideline what its effects are, so that we know, where it needs to be amended or changed. And a lot of times I think about the exceptions to the rule, because you'll have conversations about individual patients and they say, yeah, the guideline says this, but for this patient, it's not relevant.
Right.
And I think the health system loses a lot of the knowledge about when the guidelines don't fit, because we have no way of capturing that. We have no way of capturing the exceptions to the rule.
Right.
And we could come up with better and richer guidelines if we came up with systematic ways to understand exceptions to the rule. So that was the second thought that I had.
That's really interesting. And the way you describe it, I mean, we haven't really used the term living guideline, but it is a differentiating factor for our group. There have been a number, we view it as a compliment, but there's been countless groups around the country that have since replicated work-like hours at single center. But then unfortunately what they do is they say, this is the number of pills for the surgery. And we say, this is the number of pills for this surgery today, right? Because we know that in a few months that's going to change. We do think without an RCT, we're probably leveled off for general gynecologic and vascular surgery. I mean, we aren't going to get more data to say lower is better without taking some major advance. And so the struggle here in terms of implementation science is people naturally want to print the guide, stick it on their wall, and eventually it gets dust and grease because it's been up there for 10 years. We want people to go to the website so that the website can live, but driving people that way is hard, which is why we've looked at things like best practice alerts, which I tend to hate, but we've managed to make one work, and other ways through the EHR to nudge or intervene, and we're working across those domains.
Thanks for that. And I'll just then briefly mention, I think one of the struggles in the pharmacy world is, you mentioned one of the concerns in this prescribing, at the holiday or the weekend to keep, people from calling when there's not support and things like that. So that same kind of psychology of intervention, plays into the pharmacy as well, right? Pharmacists actually are often discouraged these days from calling you as a prescriber and intervening and saying, MOpen has these guidelines, and is there some reason you're not following them? And really, pharmacists are in a position to do that and certainly have the knowledge to do that, but they're not empowered to do it in our current system, unfortunately, for lots of reasons, including business reasons. And so I'm wondering if in the MOpen story, if you're looking at the pharmacy workflow at all, or if you have any interest in that.
We have 2 pharmacists who are funded directly, and we'd be happy to take that offline. We've looked at it mainly through workflow about disposal education, but I am in agreement that commercial pharmacists are not going to push back because of the business interests associated. My grandfather's a pharmacist, so I have deep and longstanding love for pharmacists, but and they've been critical to our efforts. We have created an executive guide on feedback intended for chairs and administrators for outliers. So we've tried to create, how do you do this in-house when somebody's an outlier? And we've been working with the licensing board as well. I have a very good relationship with our licensing board to think about friendly ways to get the feedback before it's the licensing board. Deep conversation.
Great. Thank you for that. Really appreciate it.
Riddhi has a question.
Hi, good afternoon, everyone. Firstly, thank you for this informative session. It totally makes sense because I've been the patient who was prescribed these many pills, and how alarmed I was knowing the fact that why was I prescribed so much after a arthroscopy of my knee surgery, and how someone actually joked, they told me, oh, you know what, if you sell these medications through wrong means, you're gonna be you can pay off your student loans. And I was like, oh my God, this is crazy. So jokes apart, thank you for this interesting research. It definitely rings a bell, and there's a correlation. My question was, being a very strong advocate to follow this of, not prescribing opioids and kind of having a substitute medication prescription, I just wanted to check with you, what could be a liability issue, or is there a liability issue when, let's say, a patient would come back saying that, oh my God, I was in so much pain, the doctor did not prescribe me opioids, and that is why I was in so much pain and was left with a disastrous outcome, and so on and so forth. So as dentists, are we liable to not prescribe something that we don't thoroughly believe in, but yet is on paper something that should have been prescribed? So just if you could share some thoughts on the ethical part of this practice.
Yeah, I think what you've pointed out is an important issue where patients are behind the times. Because as Chad mentioned, we actually have studies, we have multiple studies in dentistry, and our studies confirm these findings that acetaminophen ibuprofen mix is actually more efficacious than any opioid mix, right? So opioids are not the best pain management for dental pain. Now, we can't say that for every procedure or whatever, but we have multiple studies for dental. Now, patients have not caught up with this, right? So then therein lies a real challenge. And then the other thing is, dentistry, unlike hospitals, every practice, has to be brought on board to understand this. And then the other thing is, every member of every practice. So if the front desk person, you guys know, if you are dentists here, you know that when a patient finishes with you, that's when they have their real conversations, right? With the hygienist, with the assistant, with the front desk. They're like, this guy never gave me opioids. Now, people have to be trained to be aligned in terms of what is the policy and philosophy of the practice. So I don't think there's any ethical dilemma, because there's evidence to support this. The problem, I think, that your question, that what it highlights is that a lot of patients haven't caught up. And what Chad jokingly said, Chad has a lot more admirers than haters, including myself. But Chad, I think those folks are from the chronic pain side, right? Because we're talking about surgery and acute pain. And those people are worried that opioids will be taken out of their hand for chronic pain issues, right?
Yeah, I mean, it's true. Unfortunately, unless I write an article that says opioids are the best drug we've ever developed, I'm not going to get fanfare. And there is concern that any negative study about opioids affects people's access to chronic pain, opioids for chronic pain. Different topic. I have a lot of opinions about that as a chronic pain physician, but and I do get it, because I will say things like CDC guidelines and state policy have been weaponized and misused in places, but it doesn't change the narrative as to what's appropriate. I see a couple more questions there.
Yeah.
I see. Go ahead, Ramesh.
Yeah, Jasmine, you have a question?
Sorry. Hi, everyone. I don't have a question, but I would like to give a feedback. I have worked in a dental college practically all my life till now, but I have worked back in India, and we were situated in an area. I totally agree with your study, actually. We were situated in an area which was full of addicts. There were zones which were totally full of addicts. And because it was a border area, we never had any trouble with the pain management, be it minor surgical cases, be it major surgical cases. We used to follow ibuprofen with acetaminophen combination, which is actually excellent at pain control. And even diclofenac and acetaminophen was a good pain control agent. And sometimes in patients who reported with very acute pain, ketoconazole dispersible worked really good in those patients. We only had problem with patients who had a history of addiction. And in that case, we had to go for support to the pain clinic. They used to support it in post-operative management. But otherwise, I totally agree that we never needed opioids for minor or major surgery. And in major, if you ask what we did, was basically trauma and pathology, even ankylosis as such. We never had any trouble. So
thanks for that.
Yeah,
thanks for
sure.
that.
Thank you.
Jasmine, your house sounds just like mine.
Yeah.
Yeah, I could bring my three monsters up anytime. I've locked the door intentionally. They are locked out of the room. So my empathy should be coming through the screen. You have my empathy. I completely agree with you. What I would say is, I think counseling patients is always challenging. It's at least half of my time with a new chronic pain patient is just setting expectations and letting them know what I expect of them and what they can expect of me. I mean, I think it's that customer service model, right? What am I going to do for you, and what are you going to do? What is this training pact, this compact that you and I are going to have? I think that's critical. And many patients are not going to resonate with the idea of I want to prevent addiction. But if you tell them, I don't want you to vomit, I don't want you to be nauseous, I don't want you to be constipated, right? Those things resonate. People have had that, and I think that resonates. And I want to give you superior pain control. And so I think if you bring it up and say, hey, the licensing board's going to get me, or these attorneys are all over us, that's not going to resonate with people. But if you tell them, evidence says that I can give you great pain management without opioids and probably also avoid nausea, vomiting, and constipation, that resonates with people, I believe. So that's personally how I would approach it from an acute pain perspective.
Yeah, and then also, having practiced in Australia and now here, and then Jasmine, because your example, I think you said, was from India. There's also, a cultural difference in terms of patient expectation in pain, because I feel that here when I practice, there is an expectation for pain to be eliminated. That wasn't the case in Australia. People just want, a coping strategy. They know that they had some teeth out. They know they're going to have pain. They just don't want it to get too bad, right? So I think there's cultural difference in that is also relevant in your story there.
Yeah. I see there are questions in the chat.
I'm not hearing question has been answered. It says, what about the impact of pharma pain prescribers to write prescriptions? How has that been addressed to reduce abuse of the system?
Yeah, it's a fair question. What I will say about prescribing, at least for acute pain, is we are in an overly dominated generic market. And I'm not saying the generic market wasn't manipulated over time, but I think much of that's been done. That it's not really been big pharma for things like surgery and dentistry, because probably 98 or 99% of what we prescribe after surgery and dentistry is generic and pennies on the dollar. So there will not be cost savings by decreasing the number of pills. The cost savings come through preventing new chronic use or the care to follow if a person becomes dependent. I think the other things that can have cost savings associated with is if a person doesn't present to the hospital nauseous, vomiting, constipated. Those care episodes can be expensive, especially if they're done through an emergency department. Big pharma itself has had very little role in this space, at least here in the US. I think we're seeing this around the world, though. Purdue's Outpost, Mundi Pharmaceuticals, which is Purdue Pharma 2.0, and has oxycodone branded outside the US, are branding directly to surgeons. And I don't know about dentists, but definitely the surgeons around the world. And I know there's a study that just came out in one of the JAMA journals a couple of months ago showing that the Netherlands had an increase in oxycodone prescribing and is now seeing a correlated but delayed increase in overdose-related deaths. I still believe this to be a very clear narrative. I think the pharma angle here is really more through third-party distributors like McKesson and Cardinal Health and others that were all implicated in this last round of lawsuits that distribute most of the drug. And I don't foresee that as a current issue. And there are countless conversations we could have about how did we get here, but most of them won't change where we go. And they probably won't create productive conversation on how to do better, because ultimately, as Ramesh said in the end, and I would say in any conversation to any group of providers, we have to own personal responsibility for this situation. Whether you feel like it or not, unless you're just out of dental school, you've been part of this situation. And so own it and do better going forward. I am part of the problem. I have overprescribed my career. And so I have to own that and move on.
But that's the whole concept of the learning health system, right? Because we were not prescribing to harm people. There was not enough known at that time. And so now as we learn, I think it's Maya Angelou who says, when you know better, you do better. And so now in this process, we have been able to find better information. And so now there's different ways that we can act based on that information. Any other questions? So Brooke, what do you reckon? We call it quits, or anything else to do?
I think we are good to go if everyone is satisfied with answers that you provide and they have no more questions. I would like to say that we are recording this, and thank you so much, everyone, for joining. Is there anything else that either of you, Chad or Ramesh, want to say?
Just thanks for letting me share. Thanks for letting me come in and share today, and acknowledging Ramesh and his valuable contributions to this work. We certainly couldn't do it without his help.
All right, guys. Thank you so much.
Thanks, everyone.
Thanks.